I request Dr. Purnima to introduce our moderator for the panel discussion.
Can I have slide, please?
Dr. Manish Pandya's slide, Dr. Vishal.
So our panel discussion.
Dr. Purnima, we cannot hear. We cannot hear you.
Can you hear me now?
Yeah. Now we can.
Okay. So I welcome you, Dr. Manish Pandya, sir, as moderator for this panel discussion. Sir is professor in HOD at Mahavir Hospital, Manish IVF Center, Sai Baba Ultrasound Center. And sir is very dynamic Indian, has received award of Dynamic Indian of the Millennium by KG Foundation, Gynec Excellence Award by Foxy in 2020, Commendable Editor-in-Chief by IESRF in 2021. Sir is NBE DNB Diploma 2 seats. Sir is having 2 seats up to 2027, and total 50 residents have been passed and 2 are doing residency under Sir guidance. Sir is NARCHI recognized DGO, DCH, DRCH, DFW 2 seats. Sir is having Foxy recognized ART, IOE, IVF, ICSI and ultrasound training 2D, 3D, 4D and color Doppler center. Sir is also having. Sir has done ICOG fellowship for 6 months. 2 seats each in reproductive medicine and endoscopy. Sir is having 2 seats, and sir has published many papers in national and international journals, and total 56 42 paper in IJOGR and 5 paper in IJBCP, 3 paper in OAGG, 2 paper in IJM SPH, in IJRCOG, and 737 presentation as faculty in national and international conferences. I welcome you, sir, on this platform and honored to have you as our moderator.
So after your comprehensive introduction, I will introduce Dr. Manish as the guru and HOD of Perfection series.
Thank you, madam. Thank you for kind words. Can we have CV of our panelists, madam? Dr. Bijoy. Dr. Bijoy is there?
Yes, sir. I'm here. Can you hear me?
Yes. Dr. Bijoy is graduated from Karnataka University in 1999, done MS in 2005. 17 publications are there, and he is running a fetal medicine unit in Simar. So we should have good input from Bijoy. Welcome, Bijoy. Can I have next slide? Dr. Lalita Ambika, are you there? Latika Ambika, madam?
Yes, I am here, sir.
Yes, madam is former professor in HOD Government College, Kerala. She is senior consultant at George's Medical College, past president of Allapaja Society, and special interest in iris medicine and fetal medicine. Next panelist, Dr. Maya S. Malia. So, Dr. Maya, we are meeting first time on screen. We have got so much conversation with your husband. He is president of KOGS. Yes, he has done MD from Mysore. She is trained in laparoscopic gynec surgery, coordinator of KERSCO of KFOG gynecology, and at present partner consultant at Malia City Hospital, Karsagod. Welcome, madam. Madam Malia is there?
Thank you, sir. Thank you for giving this opportunity. Namaste.
Namaste. Now, next we have got Dr. Palvi Agrawal. She is Nova Consultant IVF Bhopal, Director of Women Clinic Bhopal. She is operating faculty in laparoscopy in ISA 2023. She has got ICOG Fellowship in Infertility, 15 publications, and good fetal medicine specialist. Welcome, Dr. Palvi. Dr. Palvi, are you there? Dr. Purnima, we are watching her. She is mastermind and permanent MOC of Perfection series. Good assistant to Dr. Monica, and after having Palvi with Dr. Purnima with Dr. Monica is just moving like Purnima's chand. So she has done MBBS in 2010, MD in 2016. She is member of National Academic Medical Society. She is trained in MI, minimal invasive surgery in Italy. She is trained in Vienna in Australia. She has got Foxy traveling fellowship at the Nagpur, ICOG fellowship at Nagpur, advanced ART training in Kiel, Germany, associated member of RCOG, 13 national and international paper, and 18 publication, including 1 good chapter. Welcome, Dr. Monica. Welcome, Dr. Purnima. You are second Monica.
No, sir. No, sir. Monica ma'am is par excellence. I am just learning under her guidance.
Next, we have got Sama Devadasan. Madam, are you there?
Yes,
sir. Yes, sir.
Namaste. Yes, ma'am. Namaste, Shama, madam.
Yes.
She is Fetal Medicine Foundation UK certified, ISAOG certified first trimester scan, Foxy trained ultrasound certificate in genetic counseling. She has held so many posts as a secretary, master trainer, member, exclusive member, and member Society of Fetal Medicine of SFM. Welcome, madam. You are from Trivandrum.
I'm
Next
from Thrissur, sir, Kerala.
Kerala.
Thank you, sir.
Thank you. Dr. Suma Vishnu. Madam Suma is there.
Yes, sir. I'm here, sir.
She is from Wayanad, Kerala. Madam, Wayanad is very beautiful. Recently,
Yes.
I had visited because aesthetic conference of dermatology was there, and my daughter was participating in there. It was a beautiful city.
Okay.
So she is from Wayanad. She has got so many posts of member in perinatology, clinical research, associate editor. She is exclusive member of Society of Fetal Medicine North Chapter, and organizing secretary of first All Kerala Perinatal Conference, invited faculty in All Kerala Conference. Welcome you all. So now we finished our 8 panelists. Another S is there. There are 3 S. Sweta, Somu, and Dr. Sama. So Sweta madam is from Delhi. She is from Bhopal. Okay, but you had done your fellowship from Sir Gangaram Hospital. Co-treasurer of Bhopal OBGY Society, Foxy Young Talent Award. She was felicitated by Cabinet Minister. Congratulations, madam. Best Award Paper, National Faculty in ISA, National Faculty in ISA 2020, co-author of chapters, 10 international publications. She has got so many scientific publications in conference, and fellowship in medical disorder from Apollo Hospital, trained in infertility, fellowship, and minimal invasive surgery, Delhi. So we got galaxy of panelists, Monica madam, from far around all the world, from Bhopal to Kerala. Can I share my presentation?
Yes.
Yes. Okay. Now you can see my presentation over there.
Yes, you can make it.
Yes, sir.
You can see over there. Okay. 1 minute. It is stuck, so again sometimes I have to relog. Slides are not moving. Just I stop share and I will share it again. Yeah. Okay. Now first slide is came. Okay, you can see my first slide.
No, we cannot.
You cannot. Okay. Just 1 second. Sorry for this technical glitch.
कल नहीं हुआ glitch तो आज हो गया ना सर?
नहीं हो गया मैडम, आ गया ना, आ गया, देखो अभी आ गया. Now you can see, because since I am the first participant na madam to join over there. Now it has came na?
Yes.
Now slide has came. Thank you. So this is my credentials. So welcome to Perfection series, Monica madam. The moment child is born, mother is also born. She is there, mother is something new. With the blessings of mother of mine, 3 books written by me is recommended in Royal College. I am fortunate that I had written Atlas of Fetal Echocardiography in 2005, and now it has gone for 2nd edition, and it is also over. The second technique of IVF made easy is also for 2nd edition, and I'm editor-in-chief of 2 journals. I must thank at this outset, because this presentation is supposed to taken by Dr. Mayank. He is a very good friend of mine. So I had taken all the slides from Mayank, and this is very good slides that we must acknowledge Mayank as well as the previous speaker, and as well as the Fetal Medicine Foundation, Mediscan, ISAOG, BC Natal, Fetal Medicine, to give us insight what we have to do in this fetal growth restriction. If patient comes in first trimester, sir has rightly mentioned, CRL is our first goal. But if patient comes in 2nd trimester, we can do dating by BPD. So to join hand with this all beautiful graphs, we have to do justice with umbilical artery and uterine artery, and everybody has rightly mentioned that now we have to depend on PI. With this knowledge, sir has rightly mentioned, growth is growth, velocity, and speed. So with the growth, we must have one starting point and one end point. In between that, we have to see the interval growth. So we must have good dating before subjecting any patients for SGA, AGA, or FGR. So we have to go this growth assessment in this interval growth, and with this we are justifiable. So every fetus has got potential to grow. Each will maintain growth potential. Some fetuses will be parallel with the 15th percentile, and failure to growth retain is FGR. So since morning we are writing FGR and FGR, and last slide of Kuldeep sir has said our ultimate goal is to reduce SB. Don't make fetus to commit suicide in utero. Reduce handicapped baby. So this is Delphi consensus based on this, and our all presentations, all are graph based on this. This is solitary criteria. If there is less than 3rd percentile, without having any doubt, we can say this is FGR. But if there is not, this is between these two, that is 4th to 9th percentile. We can include all these criteria, and we will discuss in our presentation. So 3 to 9 percentile, sometimes constitutionally small baby, and failure to growth is FGR baby. So FGR, sir has rightly mentioned early and late FGR, and with this introduction, we will go further. Now, my first question to Bijoy.
Yes.
Now, yes, Bijoy.
Yes, I can hear you.
What do you see in this graph?
I can see that only one measurement is there. I mean, it's not a serial measurement. I cannot see the gestational age very clearly because I'm joining from my phone. I'm sorry.
Yeah, no problem.
But I can see that the estimated fetal weight is sitting in between those two red lines, and that means it is optimum. And the umbilical artery and the middle cervical artery are also appearing to be within the range. Appears to be normal.
So we can see this with this simple graph. All thing is green, green, green. There is no red.
Yeah. Yes.
So we can say that curve is straight. So all curve is straight. When curve is going further, that is a straight, normal growth. Nothing to worry. Am I right?
Okay.
So
sure.
So my first impression is always see the graph. Graph is a single sheet of paper which will give you all information you need. Just you have to read the graph. So you have to become a little bit statistician. Early FGR, when we said umbilical artery is abnormal, but Kuldeep sir has rightly mentioned that late FGR, in which umbilical artery or uterine artery doesn't give that much of sense, so we have to become very much crucial. Now this is our first case. We have got 8 panelists and we have got 6-7 cases, but we will restrict to 4 cases as such time is very less. So we will divide 2 cases, 2 persons case. So first 2, that is Bijoy and Latika madam. You can take this case. This is a second gravida, previous male child, 6 years, 27 year. 27 year is the mother's age, but mean artery PI is 95th percentile. Bijoy, what you will do?
The mean uterine artery PI is high, and it's a slight predictor for FGR and preeclampsia. But in isolation, it does not work very well with a detection rate of only around 60%.
Okay.
Therefore, I generally do not use uterine artery alone unless it is used. It has to be used in combination with markers, and I prefer to use it that way. But if you do not have that facility, and if it is only the uterine artery that you're going by, it is a predictor for development of preeclampsia more than FGR. And probably I would start her off on aspirin 150 milligrams.
Fantastic. At which time would you like to give aspirin, Bijoy?
Right now itself. 12 weeks, 2 days is the
right
right
now,
time.
But at which time? Which time? Morning, afternoon, evening?
Oh, at night. Yeah, at night.
That
Bedtime.
message should go. That if you read the class study, low corroborative study of low dose aspirin in pregnancy, they specifically mention if you want very good health, you have to give aspirin at the bedtime. Okay.
Why do you think, sir, night time is important?
You say. Because you had told it is under night time.
The night time is important because of the circadian rhythm of steroid secretion in the body. So according to the circadian rhythm, the peak of all your hormones like steroids is in the morning, and therefore it is better to take it in the night. The peak of all your hormones like steroids is in the morning, and therefore it is better to take it in the night so that it controls the the circadian rhythm of steroids that are produced within the body. That's why nighttime is better. They have found that it is
Nighttime is
useful.
better.
But,
That is useful. And
in the morning time, we give thyroid hormones and steroid in the morning so that it does not suppress the circadian rhythm. Whereas we give aspirin at night so that it helps in the proper circulation of the circadian rhythm. Yes.
Maintaining the circadian rhythm. And Kuldeep sir has rightly mentioned that he will do uterine artery in the anti-scanning also. So this is, and now this is the report. Now everybody is doing double marker. Latika madam, she is positive with PAPE. Now what you will do?
Her PAPE is less than 0.4 MOM. That means she is at high risk for development of early onset preeclampsia as well as fetal growth restriction. So that adds value to the previous result of increased uterine artery pulsatility index. So that's an indication for, again, starting 150 milligram of aspirin at night.
That madam we know. But if you see, this is red mark of trisomy 21.
I am just talking about this, and as I come down, it is the risk is 1 in small letters difficult for 1 in 160.
1 in 160.
Yes, 1 in 160. So that falls into intermediate risk. We have to counsel the parents regarding risk for trisomy also, and further evaluation with either definitive testing, invasive testing, or NAPT. We have to counsel and decide. Being an intermediate risk.
So madam, you had advised and patient has undergone karyotype.
Yeah.
So this is karyotype result.
This appears to be normal.
There is something abnormal in the chromosome 9.
Okay. There's an inversion in 9 chromosome. So, what is the importance of that? I don't know what is the importance of having this small inversion in 9 chromosome. You have to have a genetic counseling and find out.
So, patient has undergone genetic counseling, and now Bijoy patient has undergone 3D sonography by you, and this is the sonography picture. So, what this picture suggests?
It's very difficult for me to call it dysmorphic, but yes, there is a slight change. But I wouldn't be too worried about just the appearance of the face. If there is nothing else, there is slightly depressed nasal bridge and all that. But
big philtrum.
Philtrum is there, upturned nose. Yeah, it's
upturned
there.
Nose.
But
So here my word is, never get carried away by 9 inversion and dysmorphic face looking on 3D, because sometimes these are misleading 3D images. Because of our angle, there is levator labor superior equine is the smallest muscle with longest name has inverted your face. But this type of face is sometimes mislead. You cannot say, as you rightly said, you cannot say it is a dysmorphic face. Now, patient has came to us on 23 week. These are her graph plotings. Bijoy, are you worried? I am very happy that you and madam had started aspirin. You see, uterine artery PA has come down.
Yes.
Otherwise, you can see every growth pattern is below 3rd percentile.
Yes.
So you can call it as a FGR. You can call it as a FGR. Okay.
Yes. The baby is small. I would say the baby is small. Yes.
Baby.
And I would call her back maybe after 2 weeks to do a follow-up.
Maybe after 2 weeks. Why 23 weeks after 2 weeks? What you will do after 24, 25?
No, I just want to see her after 2 weeks to see whether she maintains the growth velocity, and also to see whether it drops down further. Although there is no intervention that we can do at that point of time, but it would be useful to see the growth interval. Yeah.
So according to you, we had called a patient on 26th week, and these are the findings.
Yes.
Anything abnormal?
I feel that she is maintaining the growth velocity, sort of.
Interval growth is maintained.
I can see that I think it's the uterine. I can't see it very clearly. The uterines are slightly going up on both the slides, and the umbilical artery is okay. It looks okay, but the uterine artery is slightly going up. So again, I would just keep her under follow-up. That's all. I would not be worried at this stage.
So after 26 week, at which gestational age you will call her back?
Again, I would call her back after 2 weeks, because after 2 weeks she will reach the period of viability, which is 28 weeks.
Yes, fantastic,
Yes,
fantastic.
yeah.
Because that is
Yes.
individual perception of NICU limits. Our NICU limit is 29 to 20, 28 to 29 weeks. So usually we call follow-up on 28 weeks. Again, she had came at follow-up week. We can see umbilical artery PI has gone little bit high.
Yes.
You can see this is MCA PI
MCA
has also little bit gone down. But now you see newer finding is ductus venosus.
It's normal. Ductus is normal.
Ductus is normal. So according to Professor Campbell, when ductus is normal, we can wait. Madam, would you like to throw some light, Latika, madam?
See, this is gestational age is only 28 weeks.
Yeah.
So ductus venosus is normal, and umbilical artery still there is forward flow in the umbilical artery. Diastolic flow is still there, so we can definitely wait. There's no indication for termination. We will follow up.
So again, we had done follow-up at 20. So 29 weeks we had done follow-up. Again, we are in the safety net criteria. Patient is following everywhere, but you can see ductus venosus PI has gone little bit down. Madam.
Little bit up. Yeah, okay.
Little bit up.
Little bit up. No, little bit up. Still, it is below the 95th centile, and the pattern is not seen. Still, there is forward flow during atrial contraction. Then we can again wait. Or if it goes above 95th centile,
then we have to worry.
If it goes above 95th centile, or there is reverse end diastolic flow or absent end diastolic flow, then we have to worry. Otherwise, we can wait up to 32 to 34 weeks. She's only 29 weeks.
Here we can include, madam, MCA in our FGR growth chart. As such, criteria doesn't mention, but we had done MCA velocity. Is there any relevance over here?
No. At 29 weeks, MCA doesn't help us to make a decision regarding termination. At 29 weeks, actually, we have to look at the umbilical artery as well as the ductus venosus. If the umbilical artery shows absent end diastolic flow reversal, or ductus venosus is abnormal, then only we will take a decision. MCA doesn't help us to take a decision here.
So patient has again came us on 30 week, 1 day. And now?
Yes, 30 weeks, 1 day, the growth weight is going parallel. It is FGR, but not rapidly deteriorating. It is maintaining the growth velocity. And the MCA PI, and it's difficult to see for me. Weight is below 5th centile, definitely. And what is it? This is MCA.
Ductus venosus is also
Ductus venosus PA is again less than 95th centile only, and the pattern is not shown. So 30 weeks again we can wait.
You can wait.
There's no indication for termination.
Okay, madam.
Unless there is absent end diastolic flow.
Now this is patient's 8th visit. Now you see patient has got 30 week 5 days. But now safety net criteria has gone. You can see umbilical artery has got reverse flow, absent reverse end diastolic.
Okay.
Absent diastolic flow.
If there is reverse end diastolic, yes. Then what is the ductus venosus pattern? If it is more than 95th centile.
Ductus venosus is 0.8.
0.8. So at this stage, we should think of terminating between before 32 weeks. We can terminate. We can give steroids and Maxelf as indicated, and think of termination and closely monitor the fetus. At this stage, we can go for NST, computerized topography, cardiotocography, and then decide on termination. Anyway, we should not go beyond 32 weeks.
Bijoy, what is your take on this? Because at this point of time, you are also irritated. This is patient's 8th ultrasound. Patient is coming frequently from 12 week to 30 week. There is a panic button of obstetrician as well as the parents are there. What you will decide, Dr. Bijoy?
Yeah, I'm not irritated. I would definitely say that, while you're having a baby and you're following this baby up, you have mentioned the safety net, and I think the safety net is not just Doppler. We have to look at the biophysical profile and the CTG,
yes, BP,
and also
keep and CTG.
And keep a close watch on maternal BP, because 70% of them are going to develop preeclampsia. So I would keep that under close monitoring. And as you rightly mentioned, MCA is not required as a monitoring tool, because we know this baby has hypoxia, and hypoxia is not a trigger for delivery in early onset FGR. And I would continue to wait. And if this is reversed end diastolic flow after 30 weeks, then definitely delivery is an option. But if it was absent end diastolic flow, then I would have waited. But since it is reversed end
because it is reversed. So it is reversed.
So we will deliver this fetus right now because it would automatically come into stage 3. And she crosses 30 weeks.
So it is 30 week, 5 days. And we can see all these parameters are going back. Patient has got panic button. And you can see Grataco classification, it is 3-4. It already says that you don't have much time. So because MCA ductus venosus A wave is also falling well. So we have done cesarean section. So we have got 900 gram baby, 29 week, 20 days NICU. But at present, patient is of 9 years. And because of this webinar, we are not giving the patient's photo. So thank you very much for insight, Dr. Bijoy and Dr. Lalita. Now we have got Dr. Maya and Palvi is there.
Okay, sir. Yes, I'm here.
Yes, Dr. Maya. Now this is fantastic patient, new patient. Everyday patients are coming with this report. How do you interpret this report? This patient has got aneuploidy plus pre-eclampsia screening is there. She has got PIGF, she has got Down syndrome. Now patients are coming with this. No, madam, nowadays, your internet and your IT patient professional are coming with this report. Madam Malia, what you have to do?
The risk for trisomy 21 appears very high because the final cutoff, that is 1:45. So she may need chorionic with sampling to know the karyotyping. And for pre-eclampsia also, the risk appears very high.
PIGF is also
very low. Very high. So we have to rule out whether she is having the aneuploidy.
So she has got 14 week 3 days. She had got 14 week and she had came to you with this PI. So first you will start
aspirin for her.
Aspirin at the bedtime, as Bijoy had rightly mentioned that circadian rhythm is there. And now, as you rightly mentioned, that patient has got panic button of trisomy 21. So she has undergone microarray because he is wealthy patient. So we have got very good DNA chunk of 90 grams and report turnout should be normal. So we are not worried for trisomy 21. Okay, madam?
Okay.
Now she had came again at 21 week and 6 days. This is her growth pattern. And madam, rightly you had started aspirin.
Yes, it appears almost normal because PI has reduced, uterine artery PI, both the side it has reduced, umbilical artery PI is normal and growth almost in green.
So Dr. Palvi, at this juncture, would you like to add something? Is Dr. Palvi is with us? Hello? Okay, Dr. Palvi is not there. Dr. Purnima? Hello, madam. Purnima, madam.
Dr. Purnima?
Yes, sir. Yes, sir.
Would you like to do anything at this juncture? Okay, aspirin is okay. NSG is okay. She is growing well. So next visit will be?
Sir, around 28 week if everything is fine.
Everything is fine. So patient has came in, but you see, we cannot decide the destiny of patients. We have got corona. So at 22 week and 6 days, patient has got the second wave of corona with respiratory discomfort. She is admitted in our hospital and with all HRCT, prednisolone, and she is discharged on day 9. So at 22 weeks, 6 days plus 9 days of corona, she called Maya madam. Maya madam, now I am fine. I discharged from hospital. I would like to come and see whether my baby is growing well or not. What you will do?
Yeah, again we can do scanning. There is no problem.
Madam, she has got only 9 days of corona. You are not worried? You are not worried? I have to tell Dr. Malia that madam is not worried for corona. If suppose she had came after 22 weeks plus 9 days, everything is fine. We can't do anything. So better at this juncture, we can call patients after 29 weeks because this is our 28 or 20. And meanwhile, we can say patient that you do DFMC chart at your home. Let cut come out from the residual effect of corona. Then I will scan your baby at 29 weeks. Is it justifiable? Bijoy?
Yes, sir. Yes, anyway, the survival time is after 28 weeks. No, we can wait.
So we can wait. So after 22 weeks, patient has came at 29 weeks. Dr. Purnima, is this everything is going normal?
Sir, I think the growth seems normal to me. AC and weight is in normal limit, and umbilical artery PI is also normal. MCA PI is also normal. I think everything seems normal to me in these graphs.
So within one line, I can say everything is green, green, green.
Yes.
So everything you can say it is a green. Okay, it all are green. When all are green, we are happy. Okay, Maya madam.
Yes.
All is within the green.
Yes.
There is no red. There is no panic button.
Yes.
But now at 37-week patient, it came to us.
Okay.
Suddenly she developed all these hypertensive nodes. Growth is normal. Everything, umbilical artery PI is also normal. You can see MCA velocity, either we are not counting, but it is also normal. So at this juncture with this much of blood pressure and T is 37-week 2 days. Would you like to do follow-up or would you like to have chance of induction and delivery?
Even blood pressure is not very high, so 142/92, no?
It's within normal limit. We are giving labetalol, we are fine. But
Yeah.
So my point of discussion is she has undergone corona also. She had taken all this.
CPR is less than fifth. CPR is less than fifth central.
Yes, very good, madam.
So I think it's an interval point.
So you had pointed out the things which is there on the fag side. So at that time, not only looking at the blood pressure, we have to also look at the CPR. So we can give betnesol steroid at 37 week or it is not needed?
It is not needed, sir.
But if we had give, then is there any harm?
No, so there is no harm, even though guidelines say if you are doing elective section, then before 39 weeks, you should give steroids. But that's, I think.
No, we should give message. If we are giving injection betnesol at 37 week of gestation, it is not going to do any harm. It will give little bit benefit if patient is admitted in NICU, and definitely it will reduce the injection surfactant, and there is less chances of respiratory distress. Yes. Okay, so patient has undergone cesarean section because it is in the Grataco stage 1. We can wait. We can give up to certain more times, but patient is fine and we are done cesarean section. Now we are moving to another case. Is Dr. Shama and Shama is there? Or Dr. Sweta is there, or we are 4 only? Purnima madam, you can take this case.
Shweta is there?
Yeah, I'm present. Yeah.
So Dr. Purnima, you can read this.
I'm there.
Yes. So please take the new panelists. Dr. Shweta
and Dr. Suma ma'am is there.
Yeah, both of them are.
Suma madam.
Yes, sir. Yes.
So Suma madam.
Yes, sir.
This is a primary patient, natural conception, 26 weeks, 3 days, normotensive, all green. Would you worried?
No, I'm actually not worried because everything is in the normal range and she's a normotensive patient also. And I don't know why the scan was done at 26 weeks as of now.
Okay, madam. We had done 26 weeks because patient had came also on 26 weeks.
Okay.
Now,
sir.
this is 26 week graph.
Okay.
Again, it is all green.
Yes, sir.
So nothing to worry.
Yes.
But now you see, this we can see at sometimes 35 week and 3 days. Patient has come with severe oligo, AFI is 2, weight is only 1.7 kg. Because patient had lost follow-up and came again only at 35 weeks. And this is the sonography finding.
Okay.
AFI is very low. You can see there is a umbilical artery is there. This is dilatation of the renal pedicles. And this is the growth chart. This is the graph.
Okay, sir. So actually, mostly she'll be a case of late onset IUGR.
Yes, madam.
Yeah, because at 26 weeks, everything was in the normal range. And mostly she would have developed an IUGR after 32 weeks. And we are seeing
at this point.
Yes, madam. Yes, madam. At this point.
Now, at this point, like Suma had said, 26 weeks, why we did a scan is questionable. Maybe there were complaints. But in that scan, I think we see that the AC value, when you compare with the rest of it, there was a little bit of a reduction in that. Is it?
This is 26 week. And this is AC value. This is AC value. Again, it is coming on green, madam.
Yes, it is green, but the
little bit, centile is little bit less. AC centile is little bit less. So at this juncture, no, madam, you are right. That's why I had pointed this case. So don't look at all green. You can see there is something below the green. You see, it is little bit below the green. It is not on the green. Okay, madam.
Yes, sir. Yes.
So we might have missed. And she had came to us on late FGR, 1.7 kg with this much of Doppler finding. And now we can see her gestational age, and mom is here, middle cerebral artery PI is here. You can see AC is also below the third percentile. Okay, so it is 35 week, 3 days. What we will do?
Okay. Yes, sir.
What you will do, madam, at this juncture? Still you wait?
Actually, we need not terminate a late onset IUGR according to the AFI. Even though the AFI is low, and if the cerebroplacental ratio is normal, and provided she is getting good fetal movements and the NST is reactive, we can wait till 37. But she needs a close monitoring and in-house monitoring, I feel, because AFI is too low. AFI is 2 is really a thing which alerts or which causes an alarm. So if you can monitor her closely, and if the Doppler parameters are normal and NST is reactive, we can wait till 36 plus of 37. Yeah,
so message is, don't get panic button by this low AFI and severe oligo.
Yes.
Again, this is in Grataco stage 1. So you can still wait up to 37 weeks. And we had delivered this baby and she is beautiful and now everything is fine. Another case, you can have this type of situation. 32 week book patients. But unbooked patient 32 weeks came with cardiomegaly, echogenic bowel, stomach shadow, ascites, severe oligo. 2.3 in weight is only 1.1 kg, and these are our findings. You can see these two are red.
Sir, actually, RCOG has given 18 major and 10 minor criteria, in which if any of the markers, like echogenic bowel is one of the marker of RCOG. So the patient should have undergone the umbilical artery Dopplers at 26 weeks. She is a case of early onset IUGR.
Yes, madam, I know, but patient is unbooked and came at 32 week only.
32 weeks, I will also go with the umbilical artery Dopplers, and I will also see for the cardiovascular system if the baby is getting acidotic, and I will go for BPP and computerized CTG.
So this is her Doppler finding.
It's a absent and a reversal end diastolic flow is there. So the reversal is clearly seen. So we'll counsel the patient and we'll tell that we need a termination of pregnancy at this juncture.
So A wave is also deepening. At one sentence, my teacher has always told me, when umbilical become MCA and MCA become umbilical, don't think anything, fetal become acidotic. When tracing of umbilical artery just look like middle cerebral and middle cerebral artery trace form just look like umbilical, then CPR ratio will be reversed. Brain sparing effect is there. So at this juncture, we don't have to wait, but still there is a 32 weeks graph plottings over there. And we had done, this is grade 3 to 4 actions. So we had taken action as per to your guideline because there is reverse flow, and we had done cesarean section and baby is fine. Last case, madam, at which time we have to finish? 6:30? Monica madam, chai peene gayi. So primary natural conception, again unbooked case.
I'm there. You can finish at 6:30. 6:30 already. It's 6:30.
Yeah.
You can take the last case, sir.
Okay, that's why this is last case only. So primary natural conception, again unbooked, normal second trimester finding, mild PIH, severe oligo, 37 week, late onset FGR, 1.8 kg. Again, Dr. Bijoy. Dr. Bijoy, are you there? I don't see Dr. Pallavi answering anywhere. Dr. Pallavi is there? No.
Ma'am is not there, sir.
Ma'am is not there. Okay, Bijoy sir, are you there or you left? Okay, Purnima madam. These are her Doppler findings. What you will do?
Sir, Doppler, umbilical artery seems normal, MC seems normal. Sir, I think we can wait. It seems normal to me, the Doppler, umbilical artery and MCA.
So Doppler is normal. You can see all growth chart. It is also not that much bad. So curve is straight. MCAPI we are not considering, but it is low, but mean MCAPI is also there. Everything is going smooth at 32 weeks of gestation. So it is a Grataco stage 1. We can wait. We can put on this Grataco stage action, and we can have stage criteria, delivery, follow-up. Everything is there. You can use this. BCC natal are there on one line. So you can wait up to 34 to 37 week. Anything anybody want to highlight? Latika madam, Dr. Maya madam? We have to wait or we have to go for action, madam? Dr. Maya,
So depending on her maternal parameters.
Anyway, 37 weeks, no, sir.
So this is 37 week patient. So
37 weeks.
37 weeks. So we can, we have to deliver or we have to wait?
So 7 week maternal hypertension, severe IUGR, even though it is a normal Doppler, we have to think twice before waiting.
Biophysical profile we have to do, and then
because it is a term baby.
So it is a term baby. We can do. Yes. Only weight is less, so we can deliver this baby. This is last case. This is last case. Second gravida, natural conception. Last baby is normal. There is no FGR. But in second trimester, mean uterine artery PA is 95th percentile. This is 12 week. Everything is normal. But when patient has 20 week of gestation, at 20 week of gestation, she has got uterine artery PA more than 95th percentile. At this juncture, Maya madam, would you like to start aspirin? Yes or no?
It is not going to help, sir.
Yes, definitely. It is not going to help because all placent 20 weeks, 6 days. So all presentation has already undergone. You cannot modify the road. The concrete cement road is made by God to deliver the pipeline to the fetus. So at this juncture, if we give aspirin, it is not going to help anyway. Okay, this is serial chart. Anything abnormal, Maya madam? Bijoy, are you there or you had gone?
Yeah, afterwards the PA has reduced. The left uterine artery PA has reduced. Right has increased.
So we can say that on the placental side, it has reduced. On another side, contralateral side, it might have increased.
Yes, and umbilicus is okay, no problem.
Umbilicus is okay, madam.
And so growth is also okay.
So in 27 week, early FGR, fetal weight is 730 grams, severe oligo. Next visit, madam. After seeing this chart, all green.
But severe oligo.
PI is.
This is Doppler.
Reversal of flow in umbilicus. Other things are okay. DV and cerebral okay.
Cerebral okay. So we can wait.
Reversal is there, but we have to monitor every 2 days. But 28 weeks, I don't think it is going to.
So 27 weeks, 6 days. So we had waited according to our panelist. Now you can see umbilical artery is here. Ductus venosus is here. Ductus venosus is here. At 27 weeks. Dr. Suma, Dr. Shyama. Yes, Latika madam.
Yes, 27 we should wait. NST and biophysical profile also should be utilized. And also maternal condition, whether there is any hypertension.
Whether any infection?
Taken into consideration.
No, madam, there is no infection. Patient is fine, doing well. She has got no problem. Just our graph plotting has hit the panic button. Otherwise, everything for her, she is fine. So this is again Grataco stage 3 or 4. So we can wait up to 4 to 7 days or 1 to 2 days if BPP is normal.
Yeah, okay. Meanwhile, we can give steroids and all antenatal magnesium sulfate and all we can give, sir. Because anyway, we are planning for termination.
Also, we should have a discussion with the pediatrician, neonatologist, sir. Rope in them also for proper counseling with the couple. That is also important at this juncture.
So at 29 week we are terminated.
I will refer to higher center.
Then this is a summary by Isaog. It is already beautifully narrated by Dr. Kuldeep Singh. So I will narrate the latest guideline of ultrasound Isaog 2023. And this is very good paper by Determinants of Placental Ultrasound and Fetal Growth. This is the definition they had given. But most important thing is abnormal development of uteroplacental circulation and growth abnormalities are among the primary restriction of this. And mainly, ultimately, what they are taking, there is a hysterotropic nutrition. Baby is taking heterotropic nutrition. So we have to understand the main FGR is that is because of the placentation. There is the HLA C-type molecule expressed by invading extravascular trophoblast and killer cell immunoglobulins. There is a mismatch dilatation between the uterine arterioles and placenta, and invasion of the placental villi by extravillous trophoblast may result in unsuccessful penetration of extravillous trophoblast into the spiral arteriole, and this may poor development to endovascular trophoblast. Ischemia, reperfusion type of insult can cause by high pressure flow in ROS. Second, VEGF and placental growth factor, which can be detected in maternal circulation as early as 8 weeks in gestation, with increasing level up to 29 to 30. Then this is the things that defective placentation, placental growth type. We have to think all this infection, even malaria and HIV can cause FGR. So they rightly said that there is jelly-like sonographic appearance in the placenta, increasing thickness, small basal fat, focal area of decreased echogenicity due to jet-like blood flow from spiral arteries. They are confined to placental mosaicism, CPM, and they are defined CPM 1, 2, and 3. CPM 1 and CPM 2 have been shown to have little or no impact on fetal growth, while CPM 3 has been associated with preterm birth, SGA, and adverse pregnancy outcome. This is very much important, madam. We had the first case with low Pepe. It is a very good biomarker for poor placental development. And RCOG has recommended that Pepe level less than 5th percentile in first trimester has got high chances, and we have to do very good surveillance in this type of patients. Chronic histiocytic intervallation, that is CHI, is rare but immune-mediated placental disease that can occur in any gestational age and get a recurrence rate between 25% to 100%. Then CMV, madam has rightly mentioned, patient has got any infection. CMV can cause malarial infection. So if patient has got second trimester malaria, we have to think of any infection. So thank you very much, my all panelists. As time is very less, even though I tried to justice. Latika madam, senior panelist in our panel, madam, you have given very right inputs. Maya madam, Purnima madam, Shyama madam, Sama madam, and Sweta madam. Thank you very much. So at the end, our gesture that every patient should be happy. And Purnima madam, thank you very much for giving us opportunity to be part of that. And Monica madam, this is for you. Life is happy.
What is the reference you have given in the last? What is the reference, sir? Last one, which was the book that you have shown?
ISWAG opinion which had released, sir. I think that is what madam is asking.
Guidelines by ISWAG.
Madam, this is the latest guideline I had read from this. Okay, forget it. This is the madam latest ISWAG book, and this is 2023 book, and it is given all the guidelines that Pepe in first trimester, if Pepe is very low, we have to do very good surveillance. All infections are there. They can cause FGR. FGR is mainly because of placental insufficiency. So we have to look placenta as an organ. Just don't look. When I had started my ultrasonography in 1994 in Vadia. At that time, we are defining placenta in 3 types: mature, immature, and hypermature. Then it comes with calcification, without calcification. Now it is mature placenta, hypermature placenta. So placental classification has evolved since years together. We've got whole book on placental ultrasound. You don't believe, Monica madam, there is one book whole on placental ultrasound. How you look at the placenta, what are the placental abnormalities. You have to see the Nita-Buch layer. You have to see the interface between the placenta and uterine musculature. So that is the Nita-Buch layer. So you have to see the vascularity, because basically this is our dam from our baby gets feed. So if our dam is not getting good blood supply, ultimately in Gujarati we have got very good keyword, kuama hoy to wad ave. If there isn't well, then it will come for the feeding. So if well is there, am I right? If you can correct, if placenta is good, then we can have a very good nourishment to the baby. So always see the placenta. Don't just take the placenta anterior, posterior, right, left. See the placenta, see the vascularity, see the growth, see the indentation, see the calcification. And God has given beautiful placental cotyledon. Why, Monica madam, there are different cotyledons? Because there is infarction in one cotyledon. Madhya Pradesh is not giving money to Narendra Modi. Gujarat is giving. So you see, there is a one infarct.
Gujarat is always giving.
Gujarat is always giving. So starting from the embryo, thus from the fimbrial end, the ovum is engulfed into the mid portion of the tube in the ampulla, resting from beautiful Ranjit to come to meet Monica. And then there's a formation of pregnancy. Then it comes and we are putting ourselves into the uterine endometrium. We are eroding ourselves. At that time, there is a histotopic nutrition. There is no blood supply. It is a histotopic nutrition that we are taking. And that's why nowadays Ranjit is there in X-ray. Everything is coming about low oxygen. You see, low oxygen. Because at that time, it doesn't require that much oxygen. Except lung, our body has got carbon dioxide. That's why using CO2 incubator. So that low oxygen will give you the good nourishment. So if placentation is good, there is no chance of FGR. All FGR babies are SGA, but all SGA babies are not FGR.
Yeah.
Okay. So this is the message that there are determinants of placental insufficient fetal growth restriction. And these are the papers. And they said CPIM 1, 2, that gone right up to, and RCOG is recommending that if Pepe level is less than 5th percentile, we have to do surveillance. In first patient, you see Pepe was low. This is less than 5th percentile. We have to think that this patient can go for FGR. Just like if PAGF is low, we can say that this patient can for eclampsia. And always start aspirin at the bedtime in early first trimester. There is no role of aspirin after 20 weeks of gestation. Always plot graph. Just see the single sheet of graph. All green, you are happy. Curve is good. So if curve is good, then growth is straight. If curve is not good, then growth is not straight. Latika madam, anything would you like to add? Hello.
Thank you, sir. Thank you, sir, for such a nice panel questions and thought-provoking questions.
Thank you, madam. Maya madam.
It should have been useful for all the audience.
It was very useful. So many things to learn. Till like PAPP and all, now you won't take it very seriously. Once the report comes, now we'll see whether the cutoff mark is there and what is the percentage and all.
Yeah.
So all those things are important. And actually, it is a dilemma, as you told. If we follow this, whatever this staging and all, no, then we can manage accordingly.
So every patient, every ultrasound is new ultrasound. Every time you have to see patient as a, you have to do first time, because we can say the baby, first baby was normal, even though second baby has got FGR. So we cannot predict FGR. But we can have a surveillance. If you see our graphs, then we can say that we can give this baby in our ultimate goal. We don't want fetus. That we can give this baby in our ultimate goal. We don't want fetus commit suicide in utero.
Yeah.
We don't want SB. We don't want handicapped baby. My pediatrician always says, give me 900 grams of baby rather than 1.5 kg of baby with thick meconium and acidosis. I can survive 900 gram baby, I can give surfactant, but don't give me 1.5 kg baby with thick meconium and 30 to 34 week maturity. It is very difficult to survive. So thank you. Yes, thank you, Monica madam. Thank you very much.
Dr. Manish for taking us on that clinical journey, because we had good theoretical talks, we had good videos, we had good physics, Doppler, application of Doppler by radiologists, and then Dr. Manish has taken us through the clinical journey of graphs, how to interpret the graphs, how to make the graphs a part of your practice and use the graphs in your machine for your bettering your clinical.
Don't accept any ultrasound report without graph.
Yes.
Yeah.
If your radiologist is not giving you graphs, don't send your patient again to that radiologist. Always demand graph. Yeah. And always say all greens are good. All greens are there in Kerala. God's own country. Everything is green. If there is red, then have a panic button. At the last, our folksy candidate, Dr. Sunita, this is the last slide. So at this juncture, I would like to urge everyone that take your Foxy number, do the voting from 1st to 10, and we wish that Sunita become president. And thank you very much.
And I wish everybody, please see in your city that the people vote.
Yes,
the
ma'am.
vote,
Yes, sir.
Everybody votes, that minds.
That minds. So thank you very much. Thank you, sir.
Thank you all. Thank you all. Good night.
Thank you everyone for joining Perfection series, especially all faculties, all chairpersons, all panelists, my entire team, Dr. Vishal for staying till the end, all friends from all corners of the country. And the next webinar is on poor responders in the month of July after ESHRE, in which we again expect a very good clinical meeting.
Manish sir, you are coming to the ESHRE?
Yes, sir. Waiting for my passport to come.
Yes. Yeah. We have got 2 papers. We'll see you. Thank you.
Okay, sir. Thank you.